So we are talking about a retinoscopy, and now slideshow. So it could be a reflecting retinoscope, a streak retinoscope, and these are the various indications: vision not improving with the spectacle if there is no organic causes for defective vision, and suspected astigmatism to locate the correct axis of the cylinder, and children with asthenopia not cooperating for routine vision and assessment. And retinoscopy will now has got in 3 stages. We describe it: illumination, reflex, and projection stage. And in illumination stage, the light from the retinoscope illuminate a patch of retina. And this stage is common for all the refractive errors and emmetropia. And this is the starting of the retinoscopy when you can see this is the examiner's. This is the examiner side. This is the patient side. This is the principal axis. This is the retinoscope. This is the hollow in the middle of the retinoscope. And this it's been tilted, so no light is entering. This is just beginning the retinoscopy. And now you can see the retinoscope is slightly tilted. So a patch of retina is stimulated here. And now you can see that illuminated patch will act as an object and its own, and it will form an image at the far point of the eye. So image is formed at the infinity, and that is called reflex stage. So you can see that determined ray, which is coming from the upper part of the peak.
That illuminated patch will act as an object and
it is crossing the principal axis and reaching on the retinoscope. And now this it has to be projected onto the retina of the observer. The images has to be shadow. At that stage, you will be able to see the shadow at the pupillary area, and we will get a width movement in emmetropia. So you can see that determined ray is crossing the principal axis and reaching at the edge of the retinoscope and reaching at the retina of the examiner. At this stage, you will be able to see a shadow at the pupillary area. And the next is a reflex and projection stage in hypermetropia, and virtual image is formed behind the subject eye, and we will get a width moment. Here you can see that the image is formed behind this is subject patient, and this is the image which is seen behind the patient's eye. And now reflex and projection in myopia less than 1.5, image is formed behind the observer. And in this case also we'll get a width moment, and you can see that the image is here only, here the image is formed, and other optics, everything is almost the same, and it is crossing the principal axis and reaches in the retina of the observer. And reflex and projection stage, myopia of greater than 1 point, image is formed between the observer and the subject. In that case, so we will get an against movement. Here the optics is slightly different, and it is not crossing the principal axis, and image is formed between the patient and the observer. So we will get a width movement. So these are the various requirements for doing a dark room original source of light, reflecting retinoscope, trial frame, trial lenses. And this is a reflecting retinoscope. And this is a different trial lenses of different power, which has to be immediately used, selected and used. Mydriatics, it is not always necessary, but if you want, you can use mydriatics also. And advantages of mydriatics: accommodation is paralyzed, macular refraction can be estimated and useful in children, and suspected high hypermetropia. And disadvantages: it is pathological eye, periphery of the pupil may have a refraction different from the center, then give glaucoma, economic disadvantage. And how to start? Patient at 2/3 meter, and we have to start the retinoscopy. And if you are seeing no shadow, it could be a high refractive error or a medial opacity, media opacity. And in high refractive error, we have to start with the retinoscopy in a high power, either concave or convex, and then we have to fix which one will be suitable for the each patient. And if a shadow is seen, and we have to see whether it is a with or against movement, And then speed of the shadow, meridian of the shadow also has to be observed. And we'll get a width movement in myopia less than 1.5, minus 1.5 diopter, emmetropia and hypermetropia. And this is a movement, shadow is moving in the pupillary area in vertical direction. And this is how a shadow is moving in the horizontal direction. And against movement you get in myopia greater than 1.5 diopter. And if it is with the movement, you have to use a convex lens, and against movement, you have to use a concave lens. And approaching the neutralization, the speed of the shadow increase and shadow becomes smaller in size. And neutralization point, pupil filled with light and totally dark, impossible to say movement is with or against. And this is the appearance once you reach the neutralization point. At that point, we can stop the retinoscopy. And this is how we verify whether we are in the correct point by bending forward or leaning back. There will be slight variation in the movement of the shadow, or you can add 0.5 diopter addition of what is required, or deletion can be tried. Then this is how we record the retinoscopic readings accurately, vertical and horizontal or oblique axis. And some practical points are positive aberration, negative aberration, and scissor shadow. This is what you get in positive aberration, where a dark light is seen in the center and a periphery rim there is white, and it is not due to refractive error. It is due to some defect on the cornea, and we have to refer the patient for the corneal problem. Or it could be a negative refraction, a negative aberration. White is seen in the center and dark at the periphery. And this is a scissor shadow, where and the optics is, this is the optics of scissor shadow. Irregular refraction from the different part of the cornea. And you can use a streak retinoscope, and streak is a self-luminous. A light source is incorporated, and intensity and type of light beam can be controlled. And this is streak. And the method is the same as that of reflecting retinoscope. And you can see a band inside the pupil and another one outside the pupil. And this is how it does move. That is with the movement, with the one which is outside and inside are moving. And this is how it does moves against movement. Then you have to use lenses of appropriate power to arrest the movement. And this is how it neutralization point. And this is how the appearance if the streak is not in axis. And finally, after getting that recording, we record the vertical and horizontal axis, and we have to do a trial lens subjective correction, which Dr. Andrews has been elaborately explained that power axis, everything has been explained. And we have to use cross lens also, Jackson cross lens. And retinoscopy can accurately locate the axis and power of the refractive error, especially in children, for effective management of asthenopia. Thank you.